Okay, I think it worked. I think I may have solved the issue. You guys that were with me earlier, can you now hear me and see me? Or did I lose you? I just want to know that before going forward. I see the chat is up. That's a good thing. Okay, well, I'm going to go ahead and start. If I see that you guys did get lost and we're not connected, then I'll try something else. But I just apologize. I don't like that this is messing with you guys, but this YouTube thing is a little bit more tricky than it seems like it would be. So, but I do see that before I had Kimberly and I had Electra here in the chat. So if you guys are here and you can just let me know that you're still with me, that would be awesome. Otherwise, welcome to my Monday night live stream. Electra says yes. Awesome. It worked. Fantastic. Okay. All right. So we're off to a good start on a very tough topic. I'm glad that you guys are here, and I hope that others will be able to join live. So, this is part 3 of a really, really important series. And if you have been following along, whether that's live or you've been going back and watching the videos that I have been doing for the month of September, you will hear how a lot of the things I talk about tonight are going to piece together really nicely. If you haven't had a chance to do that, it's never too late. Just go back, check out those videos. I tried to do one every single week for the month of September, but with being out of town, my schedule got a little bit off, and so that didn't quite work. So I will extend this into next week, which would be the very first week of October, but that's okay. This topic is so important. I know that the calendar might say that September is National Suicide Prevention Awareness Month, but honestly, for myself and probably a lot of you guys that are watching, it's every month and it's every day that we are on this mission to save lives. And so I'm super glad that you guys are with me tonight. When you do join, I mentioned this last week. I know that sometimes it's just hard to say, hey, I'm here and I'm participating, especially when I'm talking about a topic that it's difficult and it's sensitive and it's touchy, and I get all of that. If you're inclined to tell me that you're here, I would love to be able to say hi to you. Okay, so quick introduction. I'm Kimberly Christian, and I'm a licensed clinical social worker. I have been in this field for about 16 years, and you will hear me talk about some personal ties to the topic that we're talking about tonight. You'll also hear that if you go back and watch any of the other videos on this topic. It's just a really big one. And I've tried really hard to pack these with the best of the best, the things that I want people to know more than anything. But the truth is, it's just such an ongoing topic that there's so many different layers to it that I'm just giving this really big disclaimer that it's just not possible. There's no way I can cover everything in 4 weeks' time or even 5 weeks' time that I would want you to know. And so my big encouragement to you is to keep looking, keep searching, look at the resources that I mentioned to you in this video, and just make this something that stays at the top and the forefront of your own mind. I'm going to equip you tonight with an acronym that I have pieced together from different assessment tools that I've learned over the years. And so you're going to hear me talk about SPRITE. And I just think acronyms work, and especially in something like this, when people get so concerned, obviously so, they get concerned, they get nervous, they get overwhelmed with how am I supposed to handle this if my loved one, or if I myself am feeling suicidal, what am I supposed to do? How do I take the fear out of that? Sorry, got an itch. And I'm going to equip you with remembering the acronym SPRITE. And that way, if you remember any of the pieces to this, you don't have to be a mental health professional. You do not have to be a clinician to do this perfectly. We don't even do it perfectly all the time. We have lots of tools at our access, our disposal, and we are supposed to be doing things a certain way. But the truth is that when it really counts, sometimes we just, and I mean us as, as human beings, it can be really, really difficult to remember exactly what we're supposed to do. And of course, if it is your family member or a close friend or someone you care about, you just forget about whatever the right thing to do is. And so I want to make that as simple as possible. I want to leave you guys with some things to think about, some things to practice, and I hope I leave you with some more questions. If I can stir up questions in your mind of what would this look like, or even more importantly, have I done these things? I'm going to mention a couple of things that might be brand new to some of you. And if you haven't spent time having this conversation with your loved ones or building the treatment team that I'm going to be talking about, then please make sure and do that. It's very few things are as important as what we're going to be talking about tonight. And so I am just extremely hopeful and prayerful that this video reaches all of the right people, whether it's tonight, whether it's this week, whether it's next year. I know that in my field, the conversation that we're going to have tonight and the kind of things that I will say, you may not hear from other people. If you have, that is awesome. And I would love, love, love for you to chat me and let me know who your providers are so I can just praise them for being so bold and so courageous in equipping people with how to handle situations like this. But this is something that I love doing, which is bridging faith and mental health together. And I know that I've said before in other postings, other videos that I've done, we're not encouraged to really do that. We're really supposed to be, we're told to stay in our own lane and to not let those things merge together. And I'm not doing that anymore. I'm no longer trying to stay in my own lane. I've made myself known as a faith-based therapist. And so therefore I am bringing faith into all of the topics that we talk about, because that's where I have seen people get the most help and the most long-term permanent recovery and healing, and just overall less symptoms, is when a person is a believer or they're seeking to understand faith better and they realize that skills support that in every way. So I see that we have some more people joining us. Tell me who you are if you can. I'd love to say hi to you guys. I see that Electra is here, and I think we still have Kimberly with us. Okay, so I am going to be looking at some of my notes tonight. Sometimes I just completely wing it, and hi, Pamela. You're one of the ones that hopped on. I'm so glad that you're here. Sometimes I use notes and sometimes I don't. This is one of those times that I want to remember certain pieces. And so you're going to be seeing me look down for that. Good. Kimberly, I'm glad you're still here. Mental health can be very, very costly. So this is one of the first things that I wanted to talk about. I mean, mental health treatment in general. And if you heard me talk about this in week 1, I mentioned the commonalities of people that I have seen that have really struggled with their mental health to the point of entertaining the idea of self-harm, including attempts of suicide. There's some things that they have in common that I think are important to equip us with. One of those things is that they have not had proper access to mental health. And I know that it can be very, very costly. And so what I want to be able to do is to make as much free resources, as much available as I possibly can, within, the scope of what my practice is, so that people are, there's just more and more opportunity and less excuse for people to know what they need to know the skills, know the things that it takes. Mental health can be managed. Don't let anybody tell you otherwise. It absolutely can be managed, but it does take specific things. And for some people, it is the combination of medication and therapy. For some people, maybe it really is just one of those things. But all too often, what I see is that it really does take both of those things and more. And we're going to try to cover the and more tonight. So this is going back to what I just talked about as far as the common threads that people, this is kind of a recap, but a really important one. Most people who struggle to the point of having an attempt of suicide or self-harm of any kind, there are at least two common threads that I see, and I have seen over and over and over in my own practice, working with my colleagues that I've heard about the cases that they've been treating, as well as things that are, in the media, in the news. Those are things that when I know something like that has happened, I pay attention to that, and I see this over and over again. So again, my goal in this is to empower you to know these things for yourself and for others. And the two that I see most common is that they have an unhealthy relationship with shame. You might be thinking, well, tell me more about that. An unhealthy relationship with shame. Well, so in short, shame is definitely a feeling, and we experience all feelings. But there are certain feelings, and that being one of them, that our relationship to be a healthy one needs to be one that we reject. Simply put, we do not need to experience shame at all. If it happens, it's a natural thing for it to happen to us, where we're concerned about something that we've done. We've hurt our loved ones. We've made decisions that have turned into a catastrophe for our family, for our friends, for whomever, and it manifests itself as shame in the sense of, I don't like who I am. I'm an awful person, as opposed to guilt, which is, I've done something wrong. My action is the problem, not me. And so having an unhealthy relationship with shame is that we don't really understand that we have the ability, and we have the right, and we have the authority to reject it and to say, I'm not going to believe that I am an awful person because I've done this awful thing. I can change that. I can reverse that. I can ask for help. I can find resources. I can ask for forgiveness. Right? There's so many things, and you're probably thinking it right now. In fact, I hope that you are, that all of us have done things that we are completely embarrassed of, right? Like that's the human experience. We've done things that just cause us to hold our head down in embarrassment, and we just think, gosh, I should have known better. I did know better. Why did I do that? And it turns into this just awful feeling of shame. And it communicates to us, I can't get out of this. I don't know what in the world I'm going to do. This is causing such a burden, such dismay to all of these people. It's just this ripple effect in my life. And if we don't have a healthy relationship with that, we literally think we have no options. We've ruined our lives. We've ruined the lives of other people. And those things are very real. I'm not at all minimizing that. Sometimes things happen and they're a huge, huge deal, and consequences are real, right? But what I'm talking about is not the consequences. It's the idea that we're so bad, we're so awful, that we're going to punish ourselves, because our thoughts are they're so ill, in the sense that we're telling ourselves, I can't make this right. Everybody's lives are going to be ruined as a result of this. And the only result, or the only possibility that I see in this, is for me to remove myself from this situation. So that's what I mean. It's an unhealthy relationship with shame. It's so much more healthy to realize when shame is upon us, and to correct it. To correct it by turning it into guilt, healthy guilt. Saying, yes, I spent more money than I was supposed to. I was unfaithful. I made poor decisions. I hung out with the wrong people. I did something that was very, very devastating and damaging. How can I make this right? How can I serve whatever I need to serve as the consequence? But I'm not giving myself this message of, I'm awful and I'm a burden and there's no hope. You see, it's just completely absent of hope. So an unhealthy relationship with shame is number one. The second one, you've also heard me talk about in this series, is that the person who is struggling to the point of self-harm, or attempting suicide, is not having an established relationship with mental health providers or a team, or they have pulled away. That's key. I want you to remember that, because some of you guys, sometimes you go through, the motions of staying in therapy, going through treatment, seeing your psychiatrist every few months, and there's times I know where it just weighs on you. Think, why am I even doing this? This is so exhausting, right? It is so exhausting to have to keep up with medications all the time and go to these visits, and they want to see me in person, and it just gets in the way. And sometimes I know, as a therapist, people will show up in my sessions and say, I don't even know what I'm going to talk about. I don't even know what there is to talk about. Well, we always find things to talk about, of course. But I want to say that to encourage you guys. I'm trying to pack a lot into just this one statement when I say this, but I want you to know that your time is not wasted. It is not in vain. It saves your life. Whether you're involved in individual therapy, group therapy, you've been a part of an outpatient treatment, some kind of recovery program, a community-based support group, whatever it is, if you are touching down on your mental health on a regular basis, just think about it as like, that is your health, that is your life insurance. You are giving yourself an opportunity every single week or every single whatever it is for someone to see you, to lock eyes with you, to assess you, to ask you to check in with you and to find out how you really are doing. See, it's when people pull away from that. That's why I said they may be established with mental health providers, but what I've noticed is that they have recently, I don't know exactly what that means, but they pulled away from those relationships. And so, again, as a therapist, one of the things that I do, and I think a lot of us do this, it's certainly not just me, but when we see someone that's kind of dropped out of therapy, they're not as consistent as they once were, or they're just not making it the same priority, we have the option of just kind of letting it go and looking at it as though, well, I guess they changed their mind or they found someone else. And I'm not saying that that's entirely wrong. Sometimes that's exactly what needs to happen. But our due diligence is to check on these people and to find out, what feedback do I need to know? Are you really okay? Are you pulling away from therapy because of something tough, something difficult? Is it because you're symptomatic, or am I not the right fit for you? And we need to be looking at that. So if you can see where I'm going with this, there's so much to be said about assessing, right? And that's why I wanted to do this series. There's multiple reasons for it, but one of the biggest ones is I want people, regular, everyday people, to feel confident enough in their abilities that they would know what to do in a crisis. I know some of us are great in dealing with a crisis and others are not. That's just the way that we are. We have different personalities and different strengths. But that's why I have this acronym that I want to teach you tonight, SPRITE, so that even if there's a small portion of it that you remember or that you can pass on to your loved ones, you're going to remember the next time something like this happens, how to ground yourself and to know what to do. Okay, so we're going to go through this, or I'm going to go through this pretty quickly, but if you guys have questions, put it in the chat. Let me know if there's something more you want to say about that. I am hoping to get to the point someday soon where I have someone who is assisting me in moderating the chat. I'm not quite there yet, but right now I'm going to multitask, and I'm going to teach you guys this acronym. But if you guys have questions or comments or personal experiences that you want to share and feel comfortable sharing, please do. This would be a great time for that. So the S stands for suicide inquiry. Just like I told you on week 1, the most widely held belief about this that is absolutely false, that I can just dispel right now, is asking the question does not put the thought in someone's mind. It just simply does not. So we need to be upfront and bold and just ask. So if you're ever in doubt with someone in your life, you need to ask them. But you'll see it doesn't just stop there, because some of you guys, I'm trying to not mind read, but I know enough about this topic and this field to know that sometimes you're going to ask somebody and they're going to flat out tell you no. There's reasons for that. It doesn't necessarily mean that they are trying to cover it up or lie to you. Sometimes it really means they don't think that they are. They don't realize that their mind has actually gotten to that place, or maybe they don't deem it as suicidal thoughts. Maybe it seems really normal to them, that this is just how they think. So you just simply want to ask, and this goes for yourself also. I'm trying to come at this from two different angles: the loved one as well as the client or the patient who's struggling. Ask yourself that question. If nobody else is, there in that moment, just be direct and say, what are my thoughts telling me right now? That's, to me, that is step one. As a cognitive behavioral therapist, that is step one. Take inventory of what your thoughts actually are telling you. I know it's difficult. I teach an entire class. I have an online program on this very topic of understanding what your thoughts actually are. But for tonight, just know that it is possible to sit there in the quiet, especially when your mind is really racing. Just put a pause, sit there in the quiet and ask, what is my mind telling me? I know what I'm feeling. I know I'm feeling some intense feelings and I really want to act out and I'm really upset or I'm really scared or I'm really in shame. But what is my mind telling me? There's a lot of clues. There's a lot of answers in that. So ask people, ask yourself. P. This is something that I absolutely had to learn in grad school. It makes perfect sense now. I did not know this at all. So you might be the same. P stands for protective factors. Protective factors means that you may not call it that to the person, right? That's a very clinical term. But what it means is that you are trying to find out in this person's life what value, what do they value, right? You're trying to remind them without shaming them, without causing them to feel, a tremendous amount of guilt. Like there's wrong ways of doing this, saying, well, you have so much to be grateful for. You've got this wonderful life and you've got a great income and all of those things. That doesn't help. It really doesn't help. But asking and trying to learn from this person what they value so that you can talk about that with them. Talk about their family, talk about their children, talk about their church. And in a way, you're helping to remind them of all the great support that they have, but you're also maybe helping them to see that they're not utilizing that support. Maybe they have pulled away from their church group or even going to church in general, and that was a really important thing to them. Faith in general is a huge thing. So try to understand what the person who's struggling believes in so that you're asking the right questions. This is where it gets a little dicey, I guess, because I remember going through grad school and then having my very first job as a social worker. And I'll just say that handling this carefully is really, really important because you don't want to, err on the side of certainly shaming somebody in the sense of, God condemns that. And if you do that, you're going to hell. I'm not going to touch that subject tonight. Believe it or not, I'm not going to go there. But knowing that a person believes in God and believes that he ordains their days is a very different conversation than saying, well, that suicide is a sin. There's so many issues with going down that path. I'm just going to tell you, don't go down that path. Just find out what the person believes in and encourage those things. Now, if what they're believing is just completely wrong doctrine, okay, but that's probably not the time to get into it with them. Remember, we're trying to protect. We're trying to find out the things that are valuable to them. And sometimes that's their pets. Sometimes that is their family, their friends, their job. Because in that moment, if they're at the place of thinking of causing serious harm to their own lives or death, especially, then you want to remind them of the things that their brain is telling them a lie about. Remember, this is a lot of you guys that are watching this, you probably already know this, and you can chime in and say, yes, 100% true. But I know that there's going to also be people that will watch this that may not know. And at the time where a person is struggling to this degree, what their brain is telling them is not accurate. It's not accurate. And so you need to just default to that in your own mind. You're not going to have this hugely rational conversation. That's not the time for that. But you can give them enough hope and enough of a plan, like create a healthy plan with this person of how you're going to address this with them. But trying to rationalize the irrational, that's not going to happen in that conversation. I'm just wanting you guys to know, as the loved ones, as the supportive people, you need to just assume that when someone is at the point of having suicidal thoughts, they're in such a difficult, challenging, bad place that most of what's going on in their mind is very, very real to them, but it's not real to other people. It's not reality based at all. And so this is where I'm going to kind of veer off just slightly in the faith-based spiritual part of this conversation and say, just from my heart, I just want you guys to know this is a very, very important topic. I know you know that's why you're here. That's why you've tuned in and you're watching this. One of the reasons why this is a topic that I care so much about and I'm so serious about is it's just one of the very crafty ways that the enemy finds a hole, finds an open crack, finds an open door. It's the same thing he's tried from the very beginning of time, but now it's in this form. And the lie is that God's grace is not enough. That God's grace is not enough to take care of our issues, to love us enough no matter what we've done. He finds different ways to create the same lie. And so again, I'm not making a big conversation about mental health and depression is the enemy and the devil and all those things. I'm not getting into that right now. This is all about how to prevent suicide. But I want you guys in your rational state right now to be thinking about the fact that whether it's you, whether it's someone that you love, in that moment, they are being fed some very, very serious lies. And so go into those conversations knowing that what's real to them is not real to other people, but you can still appeal to that by not just dismissing, making them, seem foolish for thinking that, or, oh, that, you're so selfish. Let's just get that out of the way. It's not selfish thinking that the person is having. Now, some of you that have been impacted by suicide, I understand very much so that there's probably been times in that grief and in that processing that you have thought that was a selfish thing because of how it impacted you. I do get that. What I'm saying is a different message. I'm saying that at the time when someone is struggling so much to fight off some really bad thoughts, their thoughts are not selfish. They're actually quite the opposite. They are thinking that they are doing something that is going to alleviate problems from their family and friends and their community. They're not thinking about what it's going to do to other people. Not in that moment, not in that state. So why do we have this assessment? It's because we have to cover a lot of ground. We have to cover a lot of ground. We don't just ask someone whether they're suicidal or not, and then, that's it. I know that a lot of people are told that. I want to give you so much more. Whether you're healing from a loss like this, whether you've experienced this yourself, or unfortunately, whether this is going to be something that you battle in the future with someone else. Because remember, this occurs, this struggle happens in 1 in every 10 families. So that's why this message is going out far and wide. Okay, P, protective factors. R, reduce risk. Reduce risk. Again, if you're taking notes while we're talking about this, you're probably thinking, well, yeah, in the moment, you're probably not thinking. You're not thinking of those things because your feelings are taking over. You're scared, you're nervous, you're thinking, oh my gosh. It takes your breath away to think that someone that you love is thinking that way. It is such a scary thing to experience. And I know that your rational brain isn't isn't operating. So consider having this acronym somewhere just close by, especially if this is something that someone in your family deals with. If any of you guys have a mental health diagnosis, you need to know this. Reducing the risk factors. So, number one, and this is something that all clinicians use, and again, you don't have to be a clinician to know this and to use this. Many times when I know one of my patients is struggling with this, first thing I want to do is pull in a family member so that I'm getting someone on the other side of their life to verify that everything that is harmful has been removed from the home. And again, I'm trying to not mind read, but I'm trying to mind read at the same time, because I know some of the questions that you guys might ask is in the mind of someone who's experiencing suicidal ideation. You want to find out in step one what it is that they're thinking. That's why the suicide inquiry isn't just about, are you having thoughts? It's, tell me what you're thinking. We need to normalize it. Instead of just completely freaking out, just ask, tell me what is in your mind. What are you thinking? Because when my patients tell me, this is what I'm thinking, this is what I'm visualizing, I want to take that seriously in front of them and then with their family or whomever is their, trusted support person in finding out how can we remove whatever that is from their home, from their easy access, right? So when someone is really struggling, is it possible that they can, find ways? Absolutely. Absolutely. But I'm telling you in a very, very supportive way, what happens is you're removing whatever it is that's going through their mind, and they've been very courageous in telling you. Now it kind of creates this out of sight, out of mind sense for a lot of people. I've had a lot of patients tell me that. Oh no. Okay, it says, okay, that's a first. The chat disconnected and now it's back. That is really odd. Okay, well, you guys will have to let me know in the chat if somehow we've lost connection, but it looks like I'm still here. Okay. Really strange. Okay, so whatever it is that the person is mentioning, you just want to take them seriously and say, okay, oh, you're still here. Electra, are you saying that we're still here? I hope so. I hope that's what you mean. Whatever it is that they mentioned, I'm not going to go through that now. Okay, Kimberly, thank you. But take whatever that method is very seriously and say, okay, together, we're going to make sure that that's not easily accessible to you, right? So it's a way of honoring the fact that they are struggling and not just saying, oh, well, I know you would never do that. Really take that seriously. Do you know how many times, if you're to actually look back at news stories where things like this happen, a lot of times I've seen this, the person has said something and people didn't take it seriously. That speaks for itself, right? We just need to take that seriously and say, okay, we are going to find a way to remove access for any of those things. But it doesn't just stop there. We also have to make sure that we are monitoring this person in a way, again, that feels very honoring and very respectful. We're not trying to make them feel like we are babysitting them. A lot of times we're talking about grown adults that are experiencing this, but we are saying, I know that this is painful. I know that this is scary for you to have these thoughts. I just don't want to leave you by yourself. So that really truly is a whole conversation where I've, spoken with families for a whole hour just about what this looks like. Every family is different. Every relationship is different. Every person struggling is really different. So think about that in your own situation and do what seems necessary. I'm trying to cover a wide array of possibilities when in the situation, I would be talking about it very individualized with that patient, what they've shared with me, what I know about that family, and I have to adjust and assess accordingly. So I meant to say this in the very beginning of the video, but it's okay that we're 30 minutes into it. just know that the best advice you're ever going to get around this topic is from someone that you are working with. They know you. They've watched you, they've listened to you, they know your diagnosis, they know the medications that you're on. So don't take what I'm saying as like the exhaustive list of everything you're supposed to be doing. This can't be personalized for you. I just want to give you sort of an insider's view as a clinician, that you don't have to hold a master's degree. You don't have to have all this training to know some of the life-saving tips that those of us that are in the field do know. I want to equip you, and I don't want you to have to work for it or have to pay for it. I just want you to know. Okay, I is intervene. So if you can tell, it's kind of ramping up. It's feeding off of whatever you knew from before, and now you're leading into the next thing. So intervene. This would include things like taking that person to the emergency room if they need it. If you know that they are really at high risk and they're telling you, I cannot promise I'm going to be safe, or anything like that, then let them know that you're going to take them to the emergency room. I have a video that I did a few weeks ago, and I'm trying to think of what the title is, but it's something to the effect of that there is no crying wolf in mental health. I think that's what I called it. In fact, I'll try to attach it to the end of this video if I remember to do that. Because the message in that video is that you take a person seriously every single time. Every single time. So if you have someone who unfortunately has sort of learned to engage with self-harming urges as a coping skill, because that happens. It's not healthy, it's maladaptive, but it happens. The best thing to do is to show that person, no matter what, whether I think you're going to be serious about this or not, when you are telling me that you cannot be safe, this is now outside of our hands. We've got to get professional help to know what to do, to look at your medication, to have you in a safe space, whatever, to look at a different level of care. So that's why that's a whole step in and of itself, is that you're intervening so that someone else is really doing the intervening. You're getting them to the hospital. Maybe even before then, you might call their individual therapist or their psychiatrist. And so really quick, I will say that for those of you that are patients that are watching this, you have a diagnosis that you're managing, please make sure that your family and your close friends have permission to contact your therapist, and vice versa. Make sure that there is that bilateral release of information, so that if they need to reach out because they have a concern, that they can. So you don't want to, call the therapist or the psychiatrist and wait around for hours if you don't hear something back. Go ahead and get them to a safe place, but let them know, I'm going to reach out to whomever your therapist is, and just let them know. Maybe they can help us on the phone. Maybe they can, meet us at the hospital if that's what needs to happen. Let them figure that part out, the professional. Okay, T is for treatment. Now, again, that sounds like an obvious thing, right? That treatment is going to be a part of someone struggling in this. What I mean when I'm making T as a part of this acronym is that you as the family member, you as the participant, need to advocate for the right level of treatment. If someone else that is a professional is minimizing this, or let me see real quick. Pamela says, is there normally someone in an ER that's qualified to handle it? That is a great question. And yes, they usually will have, in any ER, they will have typically just a regular nurse, but the nurse would know that if it is mental health related, that they triage or they assess that differently. And so they can then ask for a consultation if they need to in the ER to happen from someone from the mental health team. So I hope that makes sense. They themselves may not be qualified to go through something like this, but if they can tell from the family collateral information or from what the patient is presenting, if the person just kind of seems like they're not stable, then the hospital is going to ask for a mental health consultation from a different floor to come down and talk to them. That's a great question. So for treatment, you just want to make sure that you're advocating that the needs are met. Now, really, what goes along with this, when I said family giving collateral information, is a lot of times, people don't like being having attention put on them like this. This in its own way can feel very shaming and very embarrassing that they're being brought to the hospital and they're having these harmful thoughts. That's understandable. And as professionals, we know that. We know that you're experiencing that. So the family being able to say something like, these are the behaviors that I've seen over the last week. This is what he or she has been saying. I have reason to believe, and you can even say these things privately if you need to. You might need to find a way to be creative and see if you can pull somebody aside if you're afraid that it's going to upset your loved one. But the truth is, if you think that they're off of their important medication, their psychotropic medication that otherwise keeps them very stable, someone does need to know that. And the patient may or may not realize that. That happens. It happens too often, and it happens very, very easily. No shame, no guilt about it, extremely human. People can miss a medication, they can miss getting a refill, and before you know it, one day turns into a few days. And for some of my patients in particular, I can think of them right now. A couple of days of missing a medication is all it takes. It's not weeks. It's a couple of days, and all of a sudden, you can tell what the medication was treating. Now they're showing the same symptoms that are just catastrophic to anybody, especially to the person dealing with it. So advocate that the needs are met. Do not assume. Do not assume that the mental health professionals know everything that they need to know. I tell my patients this a lot. I'm not saying that they are not experts. I'm not saying that they're not doing a good job. What I am saying is don't assume that they know everything. They have to have information from you. They have to have proper information from you to know how to discharge that patient, what that person is going to be just discharged to. They have to know if you have suspicions that they have maybe been cutting on themselves. See, all those things are important, where someone could present one way and all of a sudden you're telling them something kind of, on a side chat, and then it changes the assessment, and it addresses what really needs to be addressed. We have to go to different measures when we are thinking about saving a person's life, because remember, what is the thing I told you earlier? Here's one assumption you can make that is very safe to make, and that is if someone is struggling in this area, they are not at their best thinking. There's no way. It's not possible. They are really struggling with distorted thinking, sometimes with irrational thinking, and they probably don't know it. Sometimes they do. Sometimes they're really skilled at this and they know something is not right. I'm having these thoughts coming back to me. This is awful. I need some help. And other times, if they're not quite so trained in knowing all the skills that it takes, they just know that they feel awful and they have no idea what could have, gotten off track for them to experience that. So the other thing I want to say about treatment real quick before moving on to the E, this is something I absolutely want to spread to as many people as possible, because I know I didn't know it. And as soon as I did know it, I've shared it in a lot of family sessions since then. And that is, after a person has been discharged from any level of care, I'm talking specifically about behavioral health, but I want you to also think if maybe someone, because time out a second. I want to make sure that I'm also addressing that addiction falls under behavioral health. Okay. So when I say that, when a person has been discharged from any behavioral health setting or where that was involved in any way, they are at higher risk for suicide for at least the first 3 months of that discharge. That's super important to know, right? Because I think it's safe. It has been a safe assumption that we think if, someone was really struggling with their mental health and they go inpatient and they are there for a week or so, and maybe they even step down to a different level of care and their medications are looked at and they're saying all the right things, and they probably feel like it's very true, like I'm safe, I'm not having those thoughts anymore. Then what happens is they get home and they're going back to their old ways. There's nothing magical that happens about, and I used to work on an inpatient unit. There's nothing magical that happens in those 3, 5, 7 days, however long they're there. Medications are looked at. They are looked at high levels where, a doctor can prescribe things and kind of play around with that a little bit because they're under a safe watch during that time. But then the person goes back to their environment. And what if all of those stressors are exactly the same? That's what I encountered a lot because I worked on the inpatient level, and then I worked at the IOP level, which is the intensive outpatient program. So I was getting a lot of the patients that had been upstairs that had attempted suicide, and they were coming into my program. And I was realizing how unbelievably raw they still were. All of those stressors that were leading them to that thought, to those feelings, to those behaviors, they're still present. Maybe the thoughts weren't as strong. Maybe they saw their family and their friends rally around for them, and that felt awesome and amazing. And it was like, oh, wow, people really do care about me. But if they're going back to the same job, if they're going back to the same unhealthy relationships, if they're going back and realizing they still have the same health issues that they had before, do you see how nothing has changed from their perspective? So you have to keep a very watchful eye, at least for the first 3 months when a person has left any of those levels of care. And that's why it's really, really important when they're leaving that level of care to make sure that they are following up with a therapist within about 7 days and following up with a psychiatrist within about 7 to 10 days. Because if they have established care previously, great. They're going right back into the hands of that awesome, supportive provider. They're following up on what changes took place. In essence, that person or those professionals are able to then assess how often that patient needs to be seen, right? Maybe they were being seen every other week or every third week. And as a result of what happened, they're saying, well, now I need to see you every 2 weeks until whatever the measurable goal is, right? So that's an important step. That's something that family members and friends can really support also, is making sure that those appointments after discharge happen. And it doesn't stop there. I mean, that's a really big piece, because remember, that's one of the things I said that people that struggle to the point of actually, acting on those thoughts have in common is that they either do not have established relationships or they've pulled away from them. And so I just can't stress enough how important those appointments are. I know a lot of patients, when they're leaving that level of care, they just want to get out. Sometimes it's been a really tough experience for them to be away from family, from their kids, from their job, from the comforts of home, and they just want to get back home, and they just want to say whatever they have to say to get out. But I'm telling you, as an insider, really make sure that they follow through on those things, because those appointments are super important. Everybody has to get on the same page. They establish how often that person needs to be seen. Sometimes that's when a multi treatment team meeting might happen, where the psychiatrist and the therapist and the patient and the family members all have a joint meeting just talking about what happened. How did we get to this point? What did we miss? How can we get in front of this for next time? So lots and lots of information there. I know I'm trying to give you guys a lot in a short time, but how are you doing? I see that Kimberly said great information. I'm so glad. If any of you guys have any other comments or questions, I want to hear it. Even if I'm talking a lot and trying to give you so much information, don't let that stop you. Okay, E, the last one in Sprite is encourage. It's encourage. I want to tell you why this is important. It takes a lot of courage for someone to share that they're struggling. I know some of you know that. So if you're the loved one or the clinician, whoever's watching this, and you're able to find out from someone that they have been having some harmful thoughts, that they have either tried to self-harm or they're constantly thinking about it, you need to congratulate them on doing the right thing and being brave and being courageous and sharing. It's really difficult, and it's downright embarrassing for some people to say, because they take it so personal that they're responsible for what they think. And I want to share this tonight, even though it's a part of a much bigger conversation, because I think spiritually speaking, it just fits into our conversation. You're not responsible for all your thoughts. You're not responsible for all your thoughts. If more people really knew that and really understood that, this wouldn't be as difficult as it is. It wouldn't be so excruciatingly hard to tell somebody, I don't know where this is coming from. I don't know what has gone on, but I am having some really intrusive thoughts about something awful happening to me, or me doing something awful to myself or somebody else. That's a really difficult thing to say, right? But if I knew that I'm not responsible for every thought that comes to me, that sometimes things just organically, biochemically happen, spiritually happen, it makes it easier for me to pull somebody to my level and say, I'm really struggling. I'm really struggling and I don't know what to do, but I have to tell somebody, because let me tell you, in sharing whatever that is that's in your mind, you are exposing the shame. And I know some of you know this, that shrinks it. I'm not saying it makes it go away. I'm not saying that it makes it never come back, never return, but it shrinks it, because shame keeps growing the more that we believe that it is a secret or that we have to keep it a secret, right? But we need to tell somebody. And you do not in any way need to take ownership over that. Just call it what it is. Say, I'm having intrusive thoughts of something happening or me doing something, and I don't think I can trust myself right now. Will you please help me? There's always, always, always people that are going to help. Again, when people are struggling to this degree, they don't think that. That's not a thought that's going in their mind. Sometimes, maybe, I'm just telling you, on average, most people are thinking, no one understands this. No one knows what to do. No one knows what I've done. No one knows how awful I am or all the secrets that I'm keeping. We want to try to keep all of that in. But you see, there's a very spiritual connection with all of this. When you're a believer in Christ and you have given him your life, I want you to think back to that time. I know a lot of you know this. You had to expose everything about you. And even if you didn't have to, it just happened, right? You could say, oh God, you don't know. You don't know all the things that I've done. You don't know how awful I am. But the truth is, he does. And what allowed you to come to him and to be known by him, to become a disciple of his, to be born again, what that took was you surrendering who you are completely and wholly, and realizing you do know, but you love me anyway. And you're the one who knows how to fix this. You know how to right the wrongs. We need to carry some of that over into our mental health situations like this and think about it in that way. Just expose it, right? Just share it with somebody that's a safe person. Someone is going to know what to do, and someone is going to love you through it. Someone is not going to be scared or shocked at what it is that you're thinking or what you've done. There are going to be people, just like the Lord, that will show you unconditional love and unconditional support and faithfulness and confidence. And I hope this video gets us a little bit closer to that. We need to have confidence in conversations like this because, as I shared last week, the verse that I gave you guys was talking about how the battle that we fight is not against flesh and blood. That's not our biggest battle, right? Our biggest battle is in the spiritual realms. It's in the things that are the evil things that happen in the world, in our own minds. And so we need to go into that battle, that mental battle, fully armed, fully equipped, knowing exactly what to do and and whom can help us through that. So God is number one. He's totally number one. But what if you find people that love him also? What if you have a church group, a community group? What if you have a therapist that you know supports your faith? I am big about telling people that are believers to find someone who aligns with your faith. I didn't used to think that that was possible or that that was a conversation that could happen because I was told that, but I no longer share that thought. I've changed my mind also. And I'm telling you guys, there is no greater counsel for a Christian than someone who's incorporating God into that with you. His ways are right. Everything else is not. Shannon says, love that exposing shame shrinks. I will definitely be adding this to my tool belt. Good. Good. Okay. Tell me what other questions, what other thoughts you guys have. I know that it's already 8 o'clock. I knew this would go by really fast. I can't read your minds right now. I don't know what you're experiencing. You might be just overwhelmed with everything that I've shared because it was pretty power packed. You might need some time to process this. We still have one more week left of this, and I've got some thoughts about how I want to address that with you. But I'll leave you with this. I want to tell you, just in the event that I don't share this next week, I have already talked about the fact that suicide is something that I have experienced in my own life as a person, in my personal life. I certainly have experienced it around in my professional life. But I will tell you that there's so many times, so many times that it is preventable. We need to have the information. We need to have the courage. We need to have the boldness to be able to have conversations and to ask tough questions and to pray on the behalf of those that are struggling. Because there is no loss like this. There is no loss like this. I will say this. Not only do I know this from people that I've worked with, my own patients that have experienced this. Thank you, Pamela. But one of my relatives is one of the ones I'm referring to that unfortunately died by suicide when I was in my 20s. And his mother, on her deathbed, so this was 25 years maybe after it happened, was still talking about this. She was struggling. She had her own memory care issues going on. A lot of things weren't rational. A lot of things weren't making sense. There was a lot of recognizing that she wasn't able to do anymore, but she still was asking questions about her son. She was still asking questions that were showing she wasn't over this, because you can't be. You just can't be over this. You can work through things. You can get better. You can process. You can heal. You can have God's holy, loving, unconditional loving arms wrapped around you, and you can get through it. But I'm just letting you know, not just me. I hope you hear this information and you share this with other people. And that if you have other topics within this that you're wanting me to talk about, you'll let me know. I'm trying to keep this to a 4-week series, but maybe that's not what's going to happen. I just know that I come back to what I said in the beginning. Mental health can be very costly. Good mental health. And I want to do my part in sharing everything that I can, as much as I can, for free, so that there is just very little reason for people to struggle and to think that there's nothing available to them. Every life matters. It's literally why Jesus died on the cross, is because every life mattered to him. And I believe that. I believe that with all my heart. So his grace is enough. No matter what we've done, no matter what we haven't done, no matter how we fall short, his grace was and is enough. There's nothing else that we could ever do to earn that. That's why it's grace. So remember that. Pamela, thank you for sharing that. I'm grateful that you guys were here with me tonight. Please, if you, I think what really helps these videos getting in more hands is when you comment. So even if you were here live tonight, comment that you watched it, comment something that was especially pertinent to you. Share this on your Instagram or your Facebook pages or whatever social media you use. We want to get this in more hands. But let me know how this has helped you. I would really appreciate knowing that. So I look forward to seeing you guys next Monday night in the month of October. Hopefully in Texas here, the weather's going to be cooling off a little bit. But thank you again for your time. And I'll look forward to seeing you guys next week. Bye.